Motor control of the body is based in three general regions of the central nervous system. There is the motor cortex and premotor areas, which have been studied. There is the cerebellum, which is the topic of our discussion today, and it can be seen here underneath the hemisphere. And there is the basal ganglia, and we are not talking about them today. That will be a different discussion. Now, let's remember a couple of basic things as we approach the anatomy and function of the cerebellum. And that is that the right hemisphere of the cerebellum works with the right side of the spinal cord. And the right side of the cerebellum works with the left side of motor cortex. That is because we have the cortical spinal tract that descends and crosses. Let me show you this diagram to remind you that neurons called upper motor neurons originating in the cortex descend all the way to the spinomedullary junction, where they cross and terminate on lower motor neurons in the spinal cord or brainstem. Thus, we have to have the cerebellum working in conjunction with the opposite cerebral hemisphere. Now, there are two types of problems that we have with cerebellum if we want to simplify it. We have problems with fine coordinated movements, which is this circuit here between cortex and hemisphere of the cerebellum. And we have problems that originate in the cerebellum and are pronounced on the same side of the spinal cord, and those have to do with posture and with gait. And of course, we also have some connections from the vestibular nerve that go to the cerebellum that have to do with control of eye movements. So let's look in more detail at the connections and the anatomy and the function of the cerebellum. I have here a left hemisphere, and it has the cerebellum and brainstem attached. So this mid-sagittal brain easily demonstrates the ventricular system, and you'll note that the cerebellum basically makes the roof over the fourth ventricle, which extends from the medulla up here to the rostral pons. And then we have the aqueduct with the midbrain, and finally we have the thalamus. So here we have the cut surface of the cerebellum, and we call this surface the vermis. It means worm. It looks more like branches on a tree. And another name for this surface is the arbor vitae, or the tree of life. Now you'll notice if we get close and examine this, we can see little bulges and dips, and those correspond for the cerebellum to the gyri and sulci of the brain. There's a very nice folded pattern, a very regular histology all through the cortex, but we're not going to discuss that in detail. We want just to look at the gross features. Now, we have three lobes to the cerebellum, and the first one is the anterior lobe, and it is separated from the posterior lobe by this primary fissure that separates the two. Otherwise, the structures look the same. And then down here at the bottom, we have the nodule, which is the name of one of these many little lobules here, but it's the only one we bother learning about. And it hangs down into the fourth ventricle and can be seen very easily. Now, let's look at this in a whole cerebellum, and let's examine both surfaces and see how the cerebellum is attached to the brainstem. So I've taken a cerebellum and put it into this skull here, just so you can see the relationship. You'll notice that it is sitting in the posterior fossa, and lying on top of this would ordinarily be the tentorium, separating the cerebellum from the occipital lobe of the cortex. And you look down in here, and you can look through and into the foramen magnum. Now I'm going to remove the cerebellum, and I want you to look on the inferior surface as I twist it like this. And this area here is called the tonsil, kind of like the tonsils in the back of your throat. The cerebellar tonsils sit right there on the edge of the foramen magnum. You can sometimes see a bit of a groove. Here we have our cerebellum now and the superior surface, but I've tricked you. I've substituted a different cerebellum because this one has the brainstem on it, and you can see the midbrain. And this region in the midline here is the vermis. And now I'm going to tip it up so you can see the inferior surface. And hopefully, I'm going to roll it over so it's a little more obvious. And I want you to now see the two tonsils on either side. You can see a groove almost where they sit on the edge of the foramen magnum. And in this normal specimen, of course, we don't have them bulging like they might be, but try to imagine if this is the medulla that I'm pressing on, and the tonsils were compressing the medulla and the cardiovascular and respiratory centers, this would be a very critical situation. So now let's look at how the cerebellum is attached to the brainstem. Here is the inferior surface with the cerebellum still present on one side, and it shows very nicely the vestibular cochlear nerve coming in here at the angle between the pons and the medulla and the cerebellopontine angle. And this small piece of cerebellar cortex out here is called the flocculus. It's kind of fluffy and flocculent sitting out here, and that is the only part of this cortex out here in the hemisphere that works with the nodule and composes the flocculonodular lobe. And we'll talk about that when we talk about eye movements and control of balance together with coordination of the eyes. Now, the three peduncles that we have that hold this cerebellum on are the inferior cerebellar peduncle, which runs right along here. It's coming up from the spinal cord, the inferior cerebellar peduncle. And since this is the medulla, when we look at a cross-section of the medulla, we will see this inferior cerebellar peduncle, which is a big landmark and is carrying proprioceptive information from the joints and tendons of all of your muscles up to the cerebellum to let your cerebellum know the status of your joints in space and the amount of muscle tension. Let's look at that in a cross-section. So this cross-section through the medulla shows the inferior cerebellar peduncle on either side. And the reason I draw your attention to it is that lesions or damage to the medulla often has cerebellar and vestibular signs because of the relationship of this inferior peduncle as it goes into the cerebellum. Also, there are axons coming out of the cerebellum through the inferior cerebellar peduncle that will interact with vestibular nuclei and reticular formation nuclei and descend to the spinal cord to influence posture and tone and help you with maintaining your balance for a smooth gait. Back to our brainstem again, it's time to discuss the middle cerebellar peduncle that extends from here to here. And it is continuous with the pons. We recognize the pons where the groove was for the basilar artery. We recognize the trigeminal nerve coming into it in the middle, and out here the vestibulocochlear nerve here in the cerebellopontine angle. The input here through the middle cerebellar peduncle is coming from pontine nuclei on the opposite side. So we have a decussation here. We have a crossing. So neurons here send their axons here. Well, you say, why is this? Well, this is part of that cortical loop where the cerebral cortex works with the cerebellum of the opposite side. So coming down from the cerebral cortex on this side, they have to make a synapse and cross to the other side. So this pathway, this descending pathway, coming down from the cortex to the pons and then crossing is for planning and programming of movements. So the cortex, in a way, says to the cerebellum, this is what I'm planning to do. This is what I want to do. And I want to consult you because you have the information coming up on the inferior cerebellar peduncle, telling about the state and tension of muscles and joints and position in space, unconscious proprioception, as we call it. So the comparator, the cerebellum, is going to compare what's going on at the moment and what is the desired cortical strategy. And then after processing that and passing it through some deep cerebellar nuclei, the information has to go back to the cerebral cortex so that the movement can be improved or continued to be practiced. And to do that, it doesn't use this middle peduncle. That's only into the cerebellum. It's going to use the superior cerebellar peduncle, but I'm going to show you that on a different specimen. So now we're looking down on another cerebellum, all right? And most of it has been removed so that you're looking into the floor of the fourth ventricle. Remember I said the cerebellum was the roof of the fourth ventricle. Well, now we're looking at the floor of the fourth ventricle where the vestibular nuclei are, and we can see the end of the fourth ventricle back down here, and it proceeds up through the colliculi and into the midbrain as the aqueduct. Now, notice here that there is a nucleus here in the cerebellum, deep. They're called the deep cerebellar nuclei, and the most obvious one is this big one called the dentate nucleus. And axons from this nucleus are the ones that are going to head back toward the cortex. They're going to go out through this superior cerebellar peduncle on either side. It more or less forms the side walls of the rostral pons. I can show you that in a section. This is a cross-section through the rostral pons. To orient you, you can see those crisscrossing fibers that we normally identify with pons, the groove from the basilar artery, and the crisscrossing axons from these pontine nuclei that you just learned send their axons to the opposite cerebellum as part of the middle cerebellar peduncle. Our focus now is on these two bands of fibers on the side of the fourth ventricle. This is the very top end of the fourth ventricle, almost the aqueduct, and this is the superior cerebellar peduncle. There's one on each side. This is the peduncle that has connections almost exclusively going forward, going rostral. This is how the cerebellum connects with the cerebral cortex, but it has to cross and it has to relay in the thalamus. So what I'm going to do is to show you where the superior cerebellar peduncle crosses to get back working with the opposite hemisphere of the brain and the motor cortex, and then I'm going to show you where it relays in the thalamus. And finally, we're going to get back to the cortex. So it's right here at the beginning of the midbrain. You can see the cerebral peduncles and the substantia nigra, the aqueduct. So right here there is sort of a whitish area that's a little brighter than the rest. Of course, I have a very good imagination. And that is the decussation of the superior cerebellar peduncle. And after the paths have crossed, you can actually see two bands of fibers on either side ascending to the thalamus. Let me show you. So here we have these two bundles now having crossed, ascending up and around the red nucleus onto the thalamus. So this is our cerebellocortical pathway, but we have to relay in the thalamus. Let's go to the thalamus. This is a coronal section through the thalamus. Here's the thalamus. We recognize it because it's on either side of the third ventricle. We see the lateral ventricles up here, the corpus callosum, the internal capsule, many of the landmarks we've come to recognize, including the mammillary body and the temporal lobe down here. Our fibers coming from the superior cerebellar peduncle that crossed are now traveling up and into this general region here, the ventrolateral part of the thalamus. From there, they synapse with neurons whose axons enter the internal capsule and travel up to either primary motor cortex or premotor cortex for planning. And so now I want to remind you that we have done a double cross. Information from motor and frontal cortex, many areas of cortex, has descended to the pontine nuclei. Those pontine nuclei have sent their axons to the opposite cerebellar hemisphere. That cerebellar hemisphere has processed the information, and based on proprioceptive input coming up from the spinal cord, has computed some sort of pattern that is necessary for the planned movement. And so neurons here in the dentate nucleus will now exit through the superior cerebellar peduncle and cross back to the thalamus and internal capsule and back up to the cortex of origin. So we have double crossed you. Cortex to cerebellum, cerebellum to cortex. So maybe it's easier to see this in a schematic. If we have cells in the cerebellum connecting with the deep cerebellar dentate nucleus, and those neurons then crossing through the decussation of the superior cerebellar peduncle up to the ventral lateral region of the thalamus, and other neurons continuing up to the motor and premotor areas of the cortex, the ultimate event that happens with this consultation with the cerebellum is coming down through the cortical spinal tract, our most important motor pathway. So for voluntary movement, there is no direct cerebellospinal pathway. So voluntary movements involve the cortex in this obscure and sort of backward way. I must stress that if you have a lesion, if you have damage anywhere in this cortical spinal tract, cortex, internal capsule, brainstem, or cord, you are unlikely to see the cerebellar signs that I'm about to show you because they are manifest on top of assuming that you have a normal functional cortical spinal tract. As preparation for looking at patients with cerebellar disease, I should mention that most of the disease involves three general regions, and they aren't usually pure. There is some overlap. Hemispheric disease results in ipsilateral limb coordination problems. Again, cerebellar disease, not cortical. Vermian problems are manifest as problems with your axial postural muscles that would influence particularly things like gait and measurement of how far you need to move your eyes to keep things in focus. And then there is this small flocculonodular lobe that has to do with eye movements and connections with the vestibular system. So let's look at some clinical examples. This woman has a form of hereditary ataxia that involves her cerebellum, and you're going to see several features of cerebellar disease that involve her upper limb. She has trouble measuring distance to put the cap on the pen. That's called dysmetria. She has difficulty with rapid alternating movements. When she approaches the accomplishment of a task like touching an object, she has a tremor that gets worse the closer she gets to the target. That's called intention tremor. And these are features of hemispheric disease. Let's look at her.
Pen on the cap on the pen. Okay, good. And now I'm going to hold the cap out here and you can put the pen on. Okay, and the other side, the same thing. Go ahead and put the cap on the pen. Good. And now just go from the tip of your nose to the tip of the pen back and forth. And I'm going to move the pen, okay? Good. Another hand.
This is the same patient, and one of the difficulties they have is rapidly executing voluntary movements. So when told to put her finger and thumb together, she has difficulty, particularly you can compare the right and left sides. And also at the end, she turns her hand back and forth on her knee, and it's a bit awkward. And this is a test for a condition called dysdiadochokinesia.
Can you just tap on one side just as fast as you can, and tap on the other side? And hold your arms like this, and just flex at the elbows. No, yeah, just like this. There you go. And I want you to just take one wrist and just rotate it back and forth, just one side. Just back and forth. And the other side. And the other side again. And this other side. Okay? And now I want you just to pat front, back, front, back, front, back. And the other side.
This same patient also has difficulty with her vermian regions, and you can see this in her difficulty with walking. So she has an ataxia of gait.
Okay, that's fine. You got your balance?
Switch hands.
Okay, that's right. That's fine. That's good. Let's go back. Okay. And if you can just turn and face the camera.
This woman is going to be given the Romberg test to see if she can keep her balance with her eyes closed. And even with her ataxia, she does not have a positive Romberg sign. Another thing that cerebellar patients do not have, contrasted with other motor problems, they have no loss of strength usually, and they have no loss of sensation. So negative Romberg, intact sensation, and no loss of strength are typical of cerebellar disease.
And you got your balance? Mm-hmm. Okay. Can you just close your eyes and stand still? I won't let you go. Stand still. You're okay. Okay, that's fine. You can open your eyes.
Okay.
This young man is doing the heel-to-toe tandem gait, as it's called, and you can see that he has difficulty walking in a straight line, and this is because his vermian regions have and anterior lobe regions have been affected by his disease.
One foot right in front of the other, like this. Okay, ready? Good, okay. Doing good. Okay.
Another example of midline vermian involvement is difficulty, particularly with the lower legs, in doing what this woman is asked to do, and that is the heel to shin. You'll see that not only does she have difficulty knowing where her limb is on her shin, but she also has some tremor involved with the activity.
Hold your leg up like this. If you can just take this heel, start at your knee, go straight down and straight back up. Just with your heel. And then back up. Okay, let's do this side. I'll hold your leg and just go for you. And then go down and then try to come back up too, slowly. Fine.
Patients with cerebellar disease involving the hemispheres also have a decrease in muscle tone or hypotonia, and when you test their reflexes, oftentimes they continue and do not stop after the first cycle, and this is called pendular reflexes. Here's an example. When tremor involves the head and trunk, we call it titubation. And this woman shows a very good example of the instability she has. She cannot stand, she can only sit, and even so, she is not stable. Nystagmus is often seen with disease of the cerebellum as well as the vestibular nerve and nuclei. Involvement of the inferior cerebellar peduncle often gives you nystagmus, and this is one example of an upbeat nystagmus. There are many forms, but this is just one. Hemisphere disease, cerebellar hemisphere disease, affects ipsilateral coordination, particularly of the upper limb. And characteristic of that are ataxia, tremor, and hypotonia. And we've seen some of the different presentations that it can have, but certainly not all of them. Vermean disease involves the midline, and particularly the areas affecting the lower limbs and truncal stability and steadiness. So we see problems of the axial musculature. The body may not be held in perfect position. You may have titubation, and there are sometimes eye problems involved, but we didn't see that. And finally, we involve the vestibulo or flocculonodular lobe, the vestibulocerebellum, and we get eye movement disturbances, the most common of which is nystagmus, of which there are many kinds, but we only looked at one. So we've come to the end of our discussion about the cerebellum, and I hope that seeing the patient videos has helped you realize that we have problems associated with the hemisphere, other problems with the vermis, and finally problems with the flocculonodular lobe.